was presented to the emergency room with 4 days of fever and rash, mostly on the extremities, with vomiting. 10 days after receiving her MMRV vaccinations, measles, mumps, rubella, and varicella, which was put in the last couple of years of the same vaccine. She received some ibuprofen and paracetamol during her fever episode, when she already experienced the fever and the rash. Okay, this is her physical examinations. We can see here the macular urticarial rash disseminated, mostly on the extremities, no oral cavity involved, skin patches, and some of the joints were swollen with high fever. Her lab results, she had a normal hemoglobin level with no anemia, but she had thrombocytopenia with 54,000 platelets, normal WBC, but moderate neutropenia. She had an elevated CRP. Electrolytes were normal and normal liver enzymes. She had a high ferritin level, which is very similar to the high CRP, which shows acute phase reactant elevation. She had an LDH of 875, normal coagulation factors, and low complement, which that was a bit surprising for us. And therefore, we continued to examine her and admit her. Her blood and urine cultures were negative. Serology for EBV, CMV, parvovirus was negative, and she was admitted during the COVID. And this is also the COVID swab, corona swab was negative. Due to neutropenia and thrombocytopenia, we also sought other explanations, and we made a chest x-ray to see that everything was normal, and ultrasound, abdominal ultrasound was also normal, no hepatosplenomegaly, no lymphadenopathy, and no hepatosplenomegaly, as I mentioned. So she was admitted and observed, which was she giving antihistamines and prednisone. And later we will reach and see what happened with her. But due to the low complement, we tried to see the history. And as I mentioned, she received 10 days pure the fever, high fever and rash, MMR vaccination. Serum sickness was first recognized as an entity as early as the 19 in patients who had received heterogeneous anti-sera, which was historically used to treat infectious diseases. We know that scientists grow diphtheria causing bacteria in the laboratory and harvested it in horse serum. And the injected horse with the diphtheria toxin then responds with immune response to that antigen and produces diphtheria antitoxin. The antitoxin is then taken out of the horse's blood serum and separated as an antitoxin rich in serum, and then is used as vaccinations and in medicine to treat certain diseases as we know today. As all we know, the serum sickness disease is a type 3 Jelen-Coombs classification. It's an immune complex adverse reaction that activates the complement system, and therefore we have the lower C3 and C4, and activates neutrophils and causes damage to the endothelial cells and vasculitis. Here it's more, it's another slide. We have the free antigen concentration that falls, antibody production increases over days, and then we have antigen-antibody complexes of various sizes that develop. The presence of the immune complex activates the complement and attracts inflammatory cells such as neutrophils. The neutrophils enzymes then are secreted and they damage the endothelial cells, as I mentioned. We know that serum sickness disease can be caused by anti-serum antigens, some even biological treatments such as anti-TNF and anti-CD20, as we can see here, and of course drugs, antibiotics, epileptical drugs, and some vaccines as well, but very, very rare. So clinical manifestation of serum sickness disease with low complement is generally appears 7 to 12 days after injection of the culprit drug or vaccination, but may appear as late as 3 weeks afterwards. Symptoms typically resolve within 2 weeks of removal of the offending agent, and symptoms can persist for as long as 2 to 3 months. So we need to take that into consideration. The onset of symptoms may be accelerated if there has been exposure with the previous allergic reaction to the same antigen. A few days before the onset of generalized symptoms, the site of injection may become edematous and red. This might give us a future that the patient will persist into serum sickness disease. Serum sickness-like is not a serum sickness disease. It's very similar clinically, and reaction forms drugs usually begin 1 to 3 weeks after the drug exposure, but complement level is normal. So this is very important. Usually the clinical manifestation rash is urticaria and rashes that are predominant type of skin eruption, as we can see here. Additional symptoms include fever, malagia, edema, lymphadenopathy, systemic arthralgia, also pain and also inflammation and arthritis involving multiple joints. It can involve the gastrointestinal complaints, including pain, nausea, diarrhea, and melena. And the diagnosis usually is made with a patient who appear moderately or severely ill. So they look bad, they have fever. CBC may be normal, but may have neutropenia and thrombocytopenia like we have at this child. ESR and CRP are usually elevated. Serum creatinine may be also elevated if there is a kidney disease involved, as we see in other vasculitis like Hillel purpura and kidney involvement. We might have mild proteinuria, hemoglobinuria, or microscopic hematuria. Complement studies, which is very indicative for serum sickness, that the complement levels 3.3 and 3.4 are generally decreased and reach a very low nadir rate at about 10 days after exposure to the antigen. We of course have to do the differential diagnosis before we state that it's a serum sickness disease. So we test for specific infectious disease, appropriate viral bacterial cultures. We might take spin biopsies, but are not usually necessary for confirming the diagnosis because the findings are variable and not specific for serum sickness. Direct immunofluorescence studies of skin lesions often reveal immune deposits of IgM, IgA, IgE, or even C3. And differential diagnosis is viral illness, as I mentioned, other vasculitis diseases like Hillel purpura, which is like post-infectious, vasculitis, lupus, scarlet fever, acute meningococcal or gonococcal infection, Kawasaki disease, acute rheumatic fever due to the arthritis, systemic onset juvenile idiopathic arthritis or Still disease, and other adverse drug reactions such as Stevens-Johnson or DRESS, which are delayed type hypersensitivity, which are the type 4 hypersensitivity reactions of gel and Coombs. These are all need to be taken into consideration. The treatment that they usually for serum sickness, as I mentioned, is primarily supportive, antihistamines, NSAIDs or analgesics, anti-pain medicine. If it's very severe, we give, of course, steroids and or orally or systemic corticosteroids. Symptoms usually last around 4 weeks for a month after the offending agent is discontinued, which suggests if it's more than 4 weeks, we have to look for another diagnosis. Prevention, seeking an alternative therapies if we know a previous reaction or if it's a very certain drug with many side effects. Neither skin tests nor in vitro studies are able to predict such a reaction because it's not a type 1 hypersensitivity Ig mediated. It's a serum, it's a type 3. So we can't do testing before we use or give the drug to the patient. We can try and not give animal-derived formulation which is possible. And it's not prevented by desensitization or pre-treatment with corticosteroids, again, because it's not an Ig-mediated type 1 hypersensitivity, so we cannot predict the reaction. And when we talk about serum sickness disease due to vaccination, we of course take into consideration the antigen itself, but we know that vaccines components known to cause allergic reactions are not just the antigen itself. We have active components additional in vaccines. Vaccines antigens themselves rarely, if ever, are the cause of hypersensitive reaction. Usually it's due to the vaccine components such as egg protein, gelatin, and potentially other additives. We know that the MMR vaccination was used to be grown on egg protein, but now they're safe, and some patients with egg protein food allergy used to not been given these vaccinations, but the new techniques of MMR vaccination are given safely to patients who are allergic to egg protein. So that's no problem, especially this patient was not allergic to any food. So it was, of course, this diagnosis was removed. Many of these components are present in small amounts that are usually insufficient to induce allergic reaction in most patients with possible hypersensitivity to the components, like gelatin or others. However, patients with unusually high levels of IgE antibody can theoretically react to a very small amount of these antigens and experience a severe reaction, including anaphylaxis, but very, very rare. And again, serum sickness disease is not a type 1 hypersensitivity Ig mediated. Talking about vaccinations, the Institute of Vaccinate Safety, when asked, do vaccines cause serum sickness, of course, have not been shown to cause serum sickness. And when I looked into the literature, of course, it's very, very rare. Several adverse reactions not previously recognized, including convulsion, allergic reactions such as anaphylactoid-like serum sickness reaction, vomiting were received, but in the vast majority of the adverse reactions. So it's very, very rare. If I looked into the literature, I've seen some cases due to H1N1 influenza vaccine and also influenza vaccine itself. Some more cases found on rabies, which is a bit more seen in more cases of a serum sickness disease of rabies vaccine after patients who were bitten by cats or dogs and were given immunoglobulin or the passive or the active vaccination of rabies. So back to our patients regarding differential diagnosis. She had neutropenia, she had thrombocytopenia, she had no high inflammation markers, just high ferritin and CRP. She has a negative viral serology. So viral infection could be that we haven't found what caused it, but the most severe viral infections were not seen. What does show that it might be a serum sickness due to the vaccine is that she had low complement, clinically similar, which is rare in vaccine reaction, but the low complement did, of course, made us think that this is the reason. Serum sickness-like reaction might be, but she had a low complement, so it's more like the disease, but less the like reaction. Regarding other adverse reaction to the vaccine, Steven Johnson, she had no criteria for it, like 10 and dressed. She didn't have the criteria for these delayed type hypersensitivity reactions. And she received ibuprofen and paracetamol during the acute fever and rash. So she didn't receive them previously. And so this is not the cause of the serum sickness disease. Her blood smear was normal, no lymphadenopathy. She had no hepatosplenomegaly. So we do think, and it's important to present this case, that it's a serum sickness disease after her MMRV vaccination. And regarding specific the patient and other patients, what is the incidence of serum sickness post-vaccination? We have only a couple of cases, and it could be any vaccination, not just the children vaccination, could be COVID or other new vaccinations or papilloma. So we need to take consideration that they might have an adverse reaction with serum sickness, very rare. Which vaccinations to give a specific patient? May they have more autoimmunity? As we know, there are many researchers regarding vaccines and autoimmunity. Do these patients who have immune complex reaction to certain vaccination have more risk of autoimmunity? It's a question that I don't have the answer. In this specific case, will we vaccinate her at 6 years of age? We know that MMRV is giving it first year and at 6 years of age. Will I vaccinate her when she turns 6 at first grade? And would I vaccinated her with other vaccinations? Thank you for listening. And I'm glad to answer the questions.
Thank you so much for your excellent presentation. Any questions from the participants?